And now we'll proceed with, again, Professor Canaud. He will have his second talk, and it will be covered the topics when to choose hemodiafiltration over hemodialysis.
Okay, so we can move. So the next topic is about the hemodiafiltration. So the question was asked when to choose hemodiafiltration instead of hemodialysis. I changed a little bit the title to put, I would say, when, why, and maybe for whom, because this is a question we want to ask. So I just want to cover a few elements. The first is, of course, if you want to move to hemodiafiltration, there is a need. So what are the current limitations of the conventional hemodialysis? How can the hemodiafiltration help to address this limitation? Okay, and what's the evidence supporting hemodiafiltration, and how can the hemodiafiltration help shaping the future of dialysis patients? So just a personalized way of caring with the patient. So what are the current limitations of conventional hemodialysis? I talked a few minutes ago about the stress, but in this slide I put the 6 main factors. The first one is the patient profile has completely changed over the last few years. They get elderly, they get more comorbid condition, they get a lot of diabetics, more, I would say, cardiovascular. So at the end, managing the patient is much more complex. It's not just based on the disease. Second point is the patient perception. So quality of life or health-related quality of life remain very poor in dialysis, maybe 40–50% as compared to the general population. Patient outcome remain poor. I just put some of the DOPs. Even if this morning we show that there is an improvement in the survival and the expectancy of life, still mortality is between 15% and 20% per year, which is tremendously high. Patient management has completely changed, and particularly now we have to consider the trajectory of the patient to identify what would be the best treatment, would be dialysis, PD, home, transplant, whatever. So you have to understand that the patient is not sitting to one treatment and need to be, I would say, in a trajectory. And also the point is medical knowledge. If you just look on the Google or PubMed, the medical knowledge now is increasing at tremendous speed. So if you just don't follow what the science is providing to you, then you are late in treating your patient. And then the last point, healthcare burden is still very high, significant in terms of cost. So we have to improve the outcome, to reduce the cost, to make sure at the end we do something beneficial for the patient. Now, what sort of tool we have? Patient outcome is not very simple. The patient outcome results from a complex chain or a complex equation. You have the patient profile, you have your hemic toxin, you have the dialyzer, you have fluxes, you have what you do, practices, and targets. And all together you need to mix to make sure at the end you achieve the best for the patient. I will concentrate on the 3 elements, which are uremic toxin, dialyzer, fluxes, and the technique. Now the point is hemodiafiltration. Hemodiafiltration is not a magic treatment. It's just a way to correct some element and particularly to focus on some specific element and particularly uremic toxin. If you just stick with the conventional dialysis, you can tackle what we know as a low molecular weight substances, but not removing or clearing what we call middle or large molecular substances. Also, there are some impact on the biocompatibility, some way of improving the inflammation, but still hemodiafiltration tried to target new element. And this is why we put in perspective the hemodiafiltration. Hemodiafiltration is a combination of diffusive action, so low molecular weight clearances, and high molecular or middle molecular weight removal by the convective action. So the dose developed by the ultrafiltration, this is a way to make a measurement about the efficiency of hemodiafiltration. So you understand at the end that the hemodiafiltration is not to increase the KT over V. The point is to increase what we want to remove, middle and large molecular substances. I will take some example, such as the beta-2 microglobulin, for example. Just an example. This is what you do with conventional, I will say, hemodialysis, high flux membrane. But if you look from the urea, vitamin B12, beta-2M as a marker, you see that the small molecular substances are very nicely removed by any membrane. But as soon as you move to high molecular weight, there is no way to remove. You need to increase the convective action. And this is exactly what we do with hemodiafiltration. So small increase of small molecular weight substances, better increase of the middle molecular substances, a tremendous increase on the larger middle, I would say, beta-2M clearances. So the target is to remove something which is not removed by the traditional. To do that, you have a technique which is called now online hemodiafiltration. Why online? Because this is a way to optimize the convective dose. If you have to buy the bag to make a substitution, it's a tremendous cost. If you use a diazide and to make a substitution, buy the diazide is almost at the same cost with the regular dialysis, provided you have the quality of water and the quality of diazide to use in your patient. So there is no reason, and you can increase the dose to what you need for your patient. I don't know here, but in Europe, 95% of the patient treated by hemodiafiltration receives the post-dilution mode, which is the most efficient in terms of clearances, but the most, I would say, cost effectiveness, because you reduce the consumption now. But you need to get a flow, you need to get a high blood flow, which also this morning difficult maybe in the Gulf area. But if you move east to Japan or Asia, we know that they are using very low blood flow, and this morning it was mentioned 200, 250. And if you do 200, 250 blood flow, you need to move to pre-dilution. There is no way to make post-dilution. So depending what you do, you have to select the technique. In Europe, is post-dilution mode, the most popular one. And again, this is a nice review from Rosner and colleagues, showing that at the end, if you link uremic toxin based on the molecular weight substances, toxicity identified, and then renal replacement therapy, and I put that on the right side of the slide, there is a way to move from diffusive to convective to remove what we are interested in. So this is exactly fitting with what I said. Convective therapy are needed to increase efficiency of our treatment. The technique is one, the membrane is another one, so this is just a way of summarizing the permeability of a membrane. We use normally or usually either the clearance, the convective clearance, or the sieving coefficient, which is a way to express the permeability. Now, you can increase the permeability of the membrane, as mentioned on this slide. The point is to be sure that at the end you are not overpassing what we call the cutoff of the membrane, which is a way to lose albumin. And this is why I put some, I would say, concern about this retention or cutoff. You have to be very careful. What you want to do with the membrane is to increase permeability for substances, but not at risk of losing albumin. And again, this is a study which is 22 years or 23 years old, showing that at the end, if you use a convective therapy like hemodiafiltration, and you take the beta-2M as a marker, there is a nice linear relationship between the convective dose and the percent reduction of beta-2M. And you see, normally, if you do 24 liters a session, which is 100 ml per hour, per minute, for 4 hours, then the reduction rate is about 70-75 beta-2M, which is 180 milligrams per liter. Now, if you do the same with a new current membrane, which is with the sieving coefficient of beta-2M, which is moved from 0.6 to 0.9, you understand that with the same convective volume, you can increase by almost 10 to 15% removal rate of beta-2M. So that means same time, same convective volume, higher efficiency. And this is exactly what different studies have shown regularly. And that's my point. If you consider that hemodiafiltration is a technique of features for renal replacement therapy, you need to change the target. And the target could be the beta-2M. This is coming from the DOPS, showing clearly that the beta-2M pre-dialysis could be a marker of risk. If you target 23, 25 milligrams per liter, you reduce your mortality of your patient. More you move up to 30, 35, you see the mortality increasing. I don't want to mention the EMO study 15 years ago, showing that 60 milligram of beta-2M was associated with this 60% increase of mortality. Okay, so keep in mind that the beta-2M could be a marker. And again, the last point is to reduce albumin loss. Different types of membrane were tested in this ex vivo study to show that at the end, you need to select the right membrane to do the hemodiafiltration, to be efficient on the removal of beta-2M or different molecules, but to prevent albumin loss. So not all the membrane fit with this high convective volume. And the last point to understand is, of course, diazer membrane, but clinical performances is a long way to go. So that means you have to consider what you want to do with your clearances, what is the body clearances depending on anthropometric of your patient, what are your operating conditions, and particularly treatment time, blood flow, diazide flow, ultrafiltration flow, and also to consider, I would say at the end, the solute mass transfer. So you need to have a very objective way to make an assessment. It's not just a selecting the technique. Now, based on the hemodiafiltration, what today we have as a sort of evidence? I put that in perspective of the domain of interest, which are the scientific relevance from the studies, the patient preferences, and the clinical judgment. And of course, we know we have the guideline. This is a long way to come with the hemodiafiltration. I just put a brief summary of clinical performances. So this is not our endpoint. We know that hemodiafiltration is the most efficient technique to remove most of the substances. It was shown by Manuel up to about 40 kilodalton. This is a way to preserve hemodynamic stability. This is also a way to reduce ESA consumption. This is also a way to reduce inflammation and oxidative stress. So this is a lot of studies have shown such an element. Now, on the same side, hemodiafiltration as a way to improve the bone disease management, not magic treatment, but reducing the phosphate and certainly improving, I would say, the mass of phosphate removed by the treatment. This is one aspect. It has also some beneficial effect on the nutritional aspect. And this is a study performed in Spain, looking on the body composition change. So based on the bioimpedance, if you do hemodialysis or hemodiafiltration, you can preserve your lean tissue mass and you can preserve lean and fat tissue mass as compared to the patient moving to hemodialysis. Preserve the cardiac health, I mentioned. Reduce beta-2M level. This is clear. Most of the study are just selected two, but this is clear. As soon as you move from hemodialysis to hemodiafiltration, you can see the reduction of the beta-2M. And the last point is, of course, a randomized study that were performed in Europe the last 10 years, showing that out of 4 studies, only one, the Eschol study, the Spanish one, was able to show a reduction of mortality by 23%. The 3 others tend to show that hemodiafiltration were not significant different with the regular hemodialysis. But that was part of the study, and that was part of the concern. Now, if you look inside this 4 study, all the studies show the same thing. But you can say this is the post-hoc analysis, but now if you divided the patient by the convective dose received from the low, 18, to the medium, 1821, and to the highest, 22 liters, there is a beneficial effect of increasing the convective volume. All the studies show the same thing. So we understand from this randomized study that the convective dose mattered. And that was confirmed by a study that we performed with a large data set, and that fit with all the randomized studies showing that if you increase the convective volume, this is expressed in liters per week, based on the 3 sessions a week, there is a beneficial effect on the survival. Left side, but also a beneficial effect on beta-2M. You see the reduction of the beta-2M. So the target could be lower, as I mentioned, than 25 milligrams per liter. And then, based on this disappointing result, because of course, randomized study, if they don't get positive, you are a little bit frustrated. So we came back with all these, I would say, investigators, and we decided to make the European HDF pooling project. So we went back to the data set of the patient, collected all the information from the patient, completed what was missing to the patient till the end of the follow-up of the patient, and the analysis was performed by independent Oxford epidemiologists. This is what we call individual patient data meta-analysis. It's not a meta-analysis of the study, this is back to the patient. And what it was shown is presented on the table. All-cause mortality was reduced in overall by 14% and cardiovascular mortality reduced by 23%. So that was the first signal showing that hemodiafiltration do something different. Now, as I mentioned, the convective volume is very important. On the left side, you get the distribution curve for the 4 randomized studies, showing that you have some on the left side and some on the right side. And you see the yellow line is about 23 liters. This is the starting point to see beneficial effect on the patient, and this is reported on the table. If you look over 23 liters, then you get beneficial effect on all-cause mortality, cardiovascular, not on the infection and sudden death, but still convincing that the convective dose make a tremendous difference. At the same time, and this is coming from real-world medicine, this is not randomized, this is national registry from different countries. France, Japan, New Zealand, Australia. All the study with a large data set of patients, up to 23,000 patients, show the same trend. All-cause mortality is reduced by 26, 37, 22%. So there is a trend to show that there is a beneficial effect. And then came CONVINCE. For those who were attending Milano meeting, that was reported, and the CONVINCE was funded by the European Union. So it's independent from any industry. This is completely independent. This is a pragmatic study performed by different centers. I will show you. Randomization, about 1,360 patients to receive either high volume hemodiafiltration, so the target was to get more than 23 liters. High flux hemodialysis, the target was to get more than 1/4. Follow-up 3 years, and the outcome I will show you in a minute. And what the CONVINCE show that relative risk of death from all cause is reduced by 23%. So confirming what I said previously. Interestingly, if you look on this Kaplan-Meier curve, you see that dissociation of the two curves start almost after 2 or 3 months, meaning that the beneficial effect is not delayed, start very early. To understand that, if you're interested, you can go to this review that we perform to understand what are the mechanisms behind to support the hemodiafiltration, and we put some direct factors and some indirect factors, but the main action is to protect the cardiovascular system. So there is a cardiac protection. So how can hemodiafiltration help? Because this is the next question. We want to personalize the treatment. So we get information from general population, and we want to move or translate to individual patient. And we know that from the SONG initiative, the patients are not interested by the KTOVV, they are not interested by the TATUM, they are not interested by the blood pressure or whatever. They are interested by the fatigue and the vascular access and some subjective assessment, clearly. Now, if you look on the hemodiafiltration, we are missing some information, but still some systematic review already on the health-related quality of life show that there is a trend. Beneficial effect on fatigue, not really on a mental component or physical component, but there are some trend in this aspect. And again, linked to the CONVINCE. I will not provide the result from the CONVINCE that will be reported at ESN, but still the CONVINCE secondary objective was to look on patient-related quality of life with a new tool, which is called PROMISE, patient-reported outcome measurement based on a computerized system. So this is a tablet, and the patient is interacting with the tablet. So it's not the SF-36. And that will be interesting because we will learn how the impact on the patient side. And the last point is, of course, personalizing is the patient perception. We want to move on a more, I would say, optimal way of treating the patient. So we need to adjust the convective dose to the patient care. To do so, and if you just consider what we observe in a CONVINCE, 23 liters substitution per square meter is about 12.4 liters per square meter. This is the minimum to achieve to make sure that your patient get better. So I put this nomogram just to explain. The blue line is the European population. On the right side, you get Middle East population. I take some example. And on the left side, you get Asian population. So you see that, of course, if you move to higher body weight or higher weights, you need to increase the volume. This is clear. But still, that give you some hint about this element. Last point, there are specific clinical conditions, particularly in Europe, with, I would say, elderly, some cardiac patients, diabetic, even the kids. And we need to adjust the treatment to such a patient. I don't want to go on the different detail, but I am interested particularly from some subpopulation, and particularly maybe the elderly, maybe the diabetics, maybe the patient on all the age, on all ventilation disease, to show that there are some beneficial effects. We learn from the convince, maybe some discrepancy, but still some beneficial effect. And the point from my side, and I am interested, and I was interested to learn this morning about the Gulf result on the DOPS. I don't understand why you are not interested to put incremental dialysis system, because that could be a nice opportunity, combining hemodiafiltration with a sort of residual kidney function, starting with once a week, twice a week, 3 times a week. This is done in UK, and you know that UK is leading this incremental concept with hemodiafiltration, showing that, again, if you put this in perspective, you can have a treatment time which is a little bit longer, less frequent treatment session, you can preserve the kidney function, and then at the end you can get better outcome. So why not, this is just a very simple suggestion, why not starting with incremental hemodiafiltration program to improve the outcome of your patient? So what is the take-home message? I would say now, worldwide adoption of the hemodiafiltration is outpacing the hemodialysis. I just put numbers. More than 400,000 patients worldwide are treated or received by the hemodiafiltration. Online is 97, 98%, so it's clearly the new standard. Average growth rate per year is 18% with hemodiafiltration versus 6.8 in hemodialysis. I just put a percentage of patients. Japan is 47, Europe is 37, rest of the world 23%. And then hemodiafiltration has attained what we call the highest level of evidence with a convince study. So it certainly establishing a new standard for renal replacement therapy today. Thank you very much for your attention.
Thank you, Canaud.